and the Berkeley Medical Research Institute. Dr. Putrino is currently the Director of Rehabilitation Innovation for the Mount Sinai Health System, a professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine. He works to develop innovative technology solutions for individuals in need of better healthcare accessibility, conducts clinical trials to investigate their effectiveness at reducing and tracking symptoms in various patient populations. Dr. Putrino is also director of the Scientific Advisory Board at Not Impossible Labs. Maybe we'll hear more about that. A group that crowdsources accessible technological solutions for high-impact humanitarian problems. His research has been featured on ABC, Sports Illustrated, The Wall Street Journal, and BBC, Time, Wired, and the LA Times, to name just a few. So we asked Dr. Putrino to talk about long COVID. I heard his webcast on the subject, and because long COVID has no current available test, this is a family medicine illness. It depends on our listening to our patients and helping them with our symptoms. And I found his explanations to be really excellent. So without any further ado, Dr. Putrino, thank you for joining us.
Oh, thank you very much for having me. And believe me, I would love to talk about all the work we do with No Impossible Labs, and I would love to talk about all the work we do in other spaces as well. But I think today, long COVID is definitely what we're here to discuss, and it will probably take up most of our time, unfortunately. But yes, I'm the Director of Rehab Innovation for the Mount Sinai Health System. Typically, what this involves is me creating new treatment pathways for novel technologies or for novel conditions. So in this case, when COVID hit, it was kind of my responsibility within the department to understand not only what were the acute ramifications of that, how do we manage COVID in the acute sense, but also what do we do post-acute? And so today I'm going to be discussing long COVID. I have no conflicts of interest to disclose that would be relevant to this particular presentation. And wanted to start off with just the general background and pathobiology, what is this condition that we're talking about? And, as Neil very, astutely pointed out, this is a clinical diagnosis. I think that we really need to make sure that to serve our patients best, we understand that nobody expects us to have a biomarker for this. If you look at the World Health Organization clinical case definition of long COVID, this is a lot of words, and I promise it's early in the morning, and this is the only slide that I'll have that has so many words on it. The clinical case definition of long COVID, really, basically, all of these words are here to basically say if you had an acute bout of COVID, an acute SARS-CoV-2 infection, and you're still not feeling right after 3 months, you have long COVID. I'll highlight a few words of the clinical case definition. Probable or confirmed. This is language that is used by both the WHO and the CDC, really to highlight the idea that doctors can diagnose long COVID even if you don't have a PCR test or an antibody test. So if somebody says, in 2020, I got this flu-y thing, I don't know what it was, COVID tests weren't available to me, but ever since I've been really just wrecked, you can still diagnose long COVID because you can say, well, that was probably COVID and you probably have long COVID. The reason for doing this was very strategic in terms of the fact that, many people who are members of historically and currently excluded groups in healthcare couldn't access tests and still can't easily access tests. And so the ability to diagnose long COVID should happen independent of that. Also, antibody tests have at best a 10% false negative rate, false negative rate. And in addition to that, the CDC tells us that about 1 in 7 people don't seroconvert. So you can have COVID and then you won't be producing antibodies shortly after that, after you've had COVID. So for all of these reasons, the CDC and the World Health Organization recommend using your clinical judgment. Does this sound like a case of COVID that this person had before they started feeling terrible? 3 months from onset is also really important. So a lot of studies into long COVID have made the mistake of diagnosing too early. So if someone is sort of, feeling unwell still 4 or 6 weeks after their COVID infection, I think it is perfectly appropriate for you as physicians to say, I'm thinking about long COVID, but I'm not yet going to diagnose long COVID at 4 to 6 weeks. So you can be considering the diagnosis without actually making the diagnosis at that time. And then, a very important piece of the diagnosis also is just the idea that symptoms, these are relapsing remitting symptoms. So people can feel well for weeks, even months, and then crash. So just be aware that that's what long COVID looks like. It is an illness that, as we'll get into later, is strongly related to viral reactivation. And so there's lots of things that can be happening which can make someone look quite healthy in the short term, but be struggling in the long term. So in terms of what long COVID looks like, the bad news is that, if we look at this paper that was published by a patient-led organization, long COVID can look like a lot of things, more than 200 symptoms here and affecting every single organ system that we know about is really what long COVID looks like. So people can come in with highly varying symptoms. The key is linking it to a new onset symptom that followed an acute bout of COVID that wasn't there before. So when we're thinking about how to diagnose, really understanding that this is a virus that really gets under our skin and can affect all parts of our physiology. So just being aware of the fact that many organ systems are affected. I would also take this opportunity to point out this is not a functional disorder. So, when we talk about, a sort of a functional neurological illness or something like that, the clinical case definition for a functional disorder is this idea that something changes in the brain, which then affects the body. We have evidence, and we'll get into this a little bit later. We have evidence to suggest that concretely, when you test organ system function, every organ system is affected. These may not be tests that are readily available to everybody, but they are tests that we can do in labs and we have published on, and therefore we know that different organ functions are being affected. So be aware that this isn't a functional neurological disorder. There are many, many organ systems that are all being affected by this illness in ways that are measurable. So, it's its own distinct illness, post-viral illness, with its own pathobiology. So the next thing I want to talk about is understanding the scope of a long COVID diagnosis, because I think that often it's there's a lot of terms flying around, and so it's hard to know what we're talking about when we're talking about long COVID. It's confusing, it's new, and I think it's worth acknowledging openly that when we say long COVID, we're talking about a spectrum of illnesses that are caused by an acute SARS-CoV-2 infection. So I like to break this down personally into what I would call syndromic, which is blue, and non-syndromic, which is purple. So on the non-syndromic side, we have all of our folks who have had very overt damage caused by the acute virus. So this is where we talk about acute kidney injury. This is where we talk about someone who had COVID pneumonia and they were on a ventilator for, 4 or 5 days, and now they have lung damage. We talk about people who have a pericarditis or a myocarditis. According to the clinical case definition, these are long COVID cases. And what's interesting or different about these non-syndromic cases is you can diagnose it. Someone comes in and they say, I'm short of breath. When I climb from the bottom floor to, my apartment with my groceries, I'm, turning blue and I'm feeling like I might pass out, and I just can't do all the things that I used to do. And then you scan them, you do a pulmonary function test and you look at their lungs and you see massive scarring. That's someone who's been damaged by the virus very overtly. And then you have syndromic cases. These are people who will often say the same thing, like, I'm short of breath, I'm fatigued, can't climb the stairs, but you scan their lungs, you can't see anything with a pulmonary function test. Their lung scan is clear. They've got, young 30-year-old lungs. So, these folks are fitting more of a syndromic diagnosis. They're having all of these new onset symptoms that are severely debilitating, but the standard medical testing isn't correlating with their symptoms. The reason I think it's important to break these two up with the understanding that there is an overlap. There is people who had severe acute disease that caused organ damage that also have syndromic elements to their illness. The reason it's important to break them up is these folks may respond well to traditional interventions. So your person who has massive lung scarring, who can't climb the stairs, they may actually respond well to pulmonary rehab if you screen them for things like post-exertional malaise. These folks have a really good chance of being worsened by traditional rehab approaches. This is the reason we need to split them up. Because individuals who are in the blue part of the Venn diagram, they're really going to experience harm when you try and say, you know what, it seems like you were just deconditioned by the virus. Let's get you on a treadmill. That will absolutely, categorically, according to the literature that has been published now and has been published for 20 years, will cause harm for someone with a post-viral illness. And so that's why we need to separate these things out. I also want to point out that there are some red herrings, and this has caused issues not just for accessing long COVID care, but in the research world as well. These are people who look like they have syndromic long COVID. They say, yeah, I got COVID 4 weeks ago. I haven't really been able to get back to feeling myself. It really knocked me out. I'm not feeling great. These are people who, may be experiencing a long tail recovery. So like I said, if they show up in your practice and they're at 4 or 6 weeks and they're saying, look, I really feel rough, like I'm not doing great. I'm not saying to minimize what they're going through. I think that long COVID should immediately be in your mind, especially if they had mild acute illness. So if they didn't really get too sick with whatever variant they caught, but it should be in the back of your mind. But we're not ready to diagnose long COVID just yet formally because it's still early, and many of these individuals go on to spontaneously recover without intervention. And the reason it's important to not jump the gun with diagnosis, and again, this is not me talking, this is the CDC. The CDC has actually altered their guidelines. They used to say 4 weeks, and now they say you start suspecting at 4 weeks. But just like the World Health Organization, you diagnose at 3 months, is because we don't want to create the narrative that the majority of folks with long COVID will recover without intervention. There was an Israeli study that was published just a few months ago that actually said exactly that. And when you dig into the methods, and the media caught hold of it, and they were like, hey, great news, most people with long COVID just spontaneously recover. When you actually dug into the methods, they diagnosed at 4 weeks. And so, yes, 70% of their cohort got better without intervention, but probably the 30% of their cohort were probably the only people with a true long COVID diagnosis. And then, I just want to give some space to the idea that we're still learning about long COVID. And so you can have previously existing complex chronic illness, whether it be post-viral illness like ME/CFS, or whether it be genetic illness like Ehlers-Danlos syndrome, or autoimmune illness like Hashimoto's, or fibromyalgia. People can have these illnesses, and we're starting to see literature. It's not yet settled science, but we're starting to see literature that these people might be more at risk of having a very rough COVID course. So just to be aware that this is still in the spectrum of long COVID. Individuals, the CDC tells us, individuals who have worsening symptoms as a result of their acute COVID infection, that still falls into the bucket of long COVID, but the pathobiology here might be slightly different to what we're seeing in, the previously healthy individual who used to run marathons who now is bedbound or housebound. And I also want to throw in the fact that, vaccine injury is indeed a thing. We are very vocal about the fact, in our center, we're very vocal about the fact that, yes, we still support vaccination. We acknowledge the fact that many people have been injured by the vaccine, and where, Science Magazine did a whole spread on this. There's a good fundamental pathobiological basis for this, and in the exploration biomarker tests that we're just starting to get underway, we're seeing that these folks with vaccine injury have all of the same biomarkers of someone with long COVID. So, we're seeing very concretely that their physiology looks very similar to someone with long COVID. So it's real, both conceptually and pathobiologically. So we should be aware of it. So for the rest of the talk, we're going to be talking about syndromic long COVID, this idea of individuals who had mild acute illness, or moderate severity acute illness, that have gone on to have these post-acute sequelae. So the next concept that I really want to discuss as we move forward is really just the idea that the pathobiology is set. I'm not here talking to you about fringe science. I'm here talking to you about science that has been published in Nature, Science, Cell, all of the top journals. And we're seeing concrete differences between folks with long COVID and folks who do not have long COVID, folks who are healthy controls. So I understand that it is really frustrating to have a whole bunch of diagnostic tests come back within normal limits, but I really want to point out the idea that, testing normal really just means that we need better tests. It doesn't mean that your patient is faking it or or not unwell. So, to that end, I want to point out, and I want to acknowledge, and I want to sort of, really just, empathize with everyone here that people will come in and they'll tell you that they're feeling awful, and you run a whole battery of tests, and either things will look perfectly normal or things will look abnormal, but not in a way that you're used to seeing. So, like their neutrophil count will be off, or, their ANA will be looking weird, or the CRP will be a little bit elevated, but not in a way that, indicates that you should be worried. So this should be the beginning of your investigation. This shouldn't be great news, everything came back normal, you're not sick. That's not what we're going for here. We need to understand that these are rapidly evolving times. Someone has come to you and said, look, I don't feel well. You run a battery of tests. And if it's linked to COVID, so if they're saying to you, I hadn't felt well until I got this flu-y thing and now I feel terrible. I think, you can provide an enormous amount of comfort to your patients just by saying, look, all the tests for really serious pathology have come back normal. This means that nothing is going terribly wrong. You're not in imminent danger. We're going to work together to sort this out, because long COVID is a thing. We don't have diagnostic biomarkers for it, but it's okay because, it's a clinical diagnosis anyway. And just the reminder, if someone comes into you and into your office and says, I can't work anymore, I can't be a dad or a mum or a caregiver anymore because of this illness, we're not here. It's not our job to ask them to prove it. It's our job to understand what's happening to their body to make them feel this way, and to work on treatments for that. And again, to that end, it would be remiss of me not to point out that long COVID, according to all of the available evidence, is classified as a post-acute infection syndrome. This places it in the same bucket as myalgic encephalomyelitis. It places us in the same bucket as people who have post-treatment Lyme disease. Yes, I believe in chronic Lyme disease, post-viral dysautonomia, et cetera, et cetera. These are people who are experiencing long tail sequelae as a result of an infection that most individuals are lucky enough to recover from. These people are not recovering. So we need to also understand that there's been a decades-long history of shaming these individuals. There's been a decades-long history of saying, all your tests came back normal, let's refer you to psych. That is not appropriate. We need to do better. And long COVID is, and I'm really thankful to be here once again, to be able to talk about this, because long COVID is often classified in the media as mysterious. It's not mysterious. We know that it is a post-acute infection syndrome. We know that it is affecting the body on every single level that we can think to test for. So it's not mysterious. It's just complex and not well characterized. And so that doesn't equal psychologizing the illness. That doesn't equal sending people off for a referral to psych. I also want to make sure that, everyone understands that long COVID is isolating and it's tough and it comes with a lot of stresses. So I often do refer patients to psych for support. But I make it clear that I don't think that their psychological symptoms are causing their illness. It's just that I feel that they could benefit from psychological support at this time because of post-viral illness that has completely destroyed their lives. And that's how I frame the referral. I also just want to point out, the idea that post-acute infection syndromes, pathobiology is moving. We call these dynamic disabilities for a reason, meaning that, this is a figure taken from a paper that myself and my wonderful collaborator, Akiko Iwasaki, published in The Lancet earlier this year, where we talked about some of the four big drivers of long COVID symptomology. And we tried to make the point that, sometimes these drivers are very prominent. Sometimes you can take a blood test from someone with COVID, and according to the work of David Walt at Harvard, you will see spike proteins, viral spike proteins circulating in the bloodstream, which could be pushing chronic inflammation and autoimmunity and all sorts of issues. And other times when they're, if you remember the clinical case definition, relapsing, remitting, when they're feeling well, you'll take their blood and it will look perfectly fine. So just understanding that there are many drivers. The reason we call it complex chronic illness is there's not a single biomarker. There's not a single magic bullet that is going to fix these individuals. We need to do a deep dive and understand what's happening in their physiology in a very dynamic way to be able to treat. So, I'm really, I was so excited when family medicine reached out because, I think family medicine is often this specialist generalist specialty where you often have a lot of things coming at you, and you need to understand, okay, well, this is happening because of, immune dysfunction, and this is happening because of, cardiogenic illness, and this is happening because of something completely different. The adage that we often, apply in medicine of Occam's razor, and it's much more likely to be one thing than, two things occurring simultaneously, or three or four or five things occurring simultaneously, doesn't apply with post-viral illness. Often with post-viral illness, it is three or four or five things happening simultaneously. So you need to be very aware of that in your approach to management. And again, just a reminder that you're also going to see weird things that are hard to understand or hard to explain to your patients, because we still, a lot of the research that has been done on long COVID to date has been very clean research saying, okay, we want a whole bunch of people who were previously healthy, and we're going to study them now that they have long COVID. So we still don't know how someone with diabetes that they've been managing for 30 years presents with long COVID. We still don't know much about how someone who is battling breast cancer and taking a whole bunch of immune therapies and chemotherapies presents with long COVID. So, there is no single classic presentation of long COVID from a biomarker perspective that tells us this. This is a topic all on its own, so I don't want to spend too much time, but this is a figure that was taken from a brilliant review paper that I would recommend everyone read, that was published in Nature Microbiology, that really goes through some of the likely leading underlying causes. And I just want to point out on this slide that everything from viral persistence and immune dysregulation, microbiome disruption, autoimmunity, endotheliitis, microclot formation, platelet hyperactivation, and neurological dysfunction, every single panel on this slide, there has been hard evidence published in journals, vanity journals, Nature, Cell, Science, etc., showing that individuals with long COVID have hard evidence that of these things going on in their body that differentiates them from the general population. My team alone, has published a paper showing that if we just take your blood and look at your blood through, a fairly comprehensive immune lens, we can differentiate people who had long COVID from people who did not have long COVID with 96% accuracy, just from looking at their blood. So, I just want to put this slide in to say, the science is settled. The biomarker discovery work is ongoing, and I hope that we can translate it to, clinical practice quickly. But in the meantime, in the same study where we, which I was just talking about, which is Klein et al., in the same study where we were able to show that we could classify people with long COVID with 96% accuracy from their blood, we could classify them compared to controls from their subjective symptom reporting with 92% accuracy. So, and the folks that we classified as having long COVID correlated with the folks that the machine learning algorithm classified as having long COVID from their blood biomarkers near perfectly. So basically, our Cohen's kappa was almost 1, as we were trying to understand how much does the machine learning algorithm agree with our clinical intuition. So all of this, I know I've spent like 20 minutes talking about pathobiology, but I would bring it right back to the idea that CDC, World Health Organization, NIH tell you this is a clinical diagnosis. So if you just listen to your patients and you hear them say, I'm fatigued, I'm having heart palpitations, I'm not living the way I used to live since I had this virus, that is enough to say, I think you have long COVID. And my final thought on this is, again, just understanding that this is not a single disease process with a single pathobiological biomarker with a single cure. You need to think about complex chronic illness differently, and you need to think about it conceptually as a ship with 3 anchors down. If your patient is the ship and they're feeling like they can't move on from their symptoms, you need to try and understand how many anchors they have down. Because if you say, well, I'm going to treat you for viral persistence, here's some Paxlovid, and you pull up that anchor and they're like, no, doc, I'm still not feeling better. Conceptually, are you going to throw that anchor down and start pulling up another anchor? Because that's still not going to move the ship. So what we need to think about with complex chronic illness is, okay, I need to work out all of the things you have going on, and I need to pull up all of the anchors. Otherwise, this ship isn't going to move. And once again, it comes back to, we're often trained to think about, it's much more likely to have one thing that explains all of your symptoms than many things going on simultaneously. Yes, that's true, except in the world of post-viral illness. In post-viral illness, many things can be going on. So that means we need to treat many things at once. So that's my whole spiel on long COVID pathobiology. Well, what do we do about it? I'm hoping that out of this talk, you'll get some, pragmatic tips. The first tip that I would give is just making sure that that we really support the community by objectively measuring things that people are reporting to you. So when someone says that they're feeling fatigued, I'm really tired, I can't get out of bed, I don't know what's happening to me, I used to be very active, et cetera, et cetera. Okay, well, how fatigued are you? Let's really dig into that. So this is some data that was taken from one of our studies where we looked at folks with long COVID compared to people who had fully recovered or self-reported to be fully recovered from COVID. And as you can see on a visual analog scale of fatigue, which is part of what we call the fatigue severity score, which is a well-validated questionnaire for fatigue. People with long COVID were significantly more fatigued than people who had fully recovered. Same with neurological quality of life, which is a cognitive function test. Same with health-related quality of life. We measured the EQ5D5L, which looks at how much your illness is interfering with your, ability to have good quality of life. So in all of these situations, we're seeing concrete differences in the way that people present. Now, the reason this is important is because from the minute as someone with a post-viral illness who's struggling to cope with daily life, from the minute they walk into your office, if you're writing down patient reports fatigue, patient reports heart palpitations, patient reports cognitive, brain fog, which is, the term that gets passed around. If that's all you're reporting, but you're not going deeper to actually measure what they're reporting, so you're not leaning in and saying, well, actually, we have validated instruments to understand how fatigued you are, the fatigue severity score, how much your cognitive function is impairing your quality of life. If you're not measuring these things, when it comes to getting insurance coverage or short and long-term disability coverage, I can promise you already, you're going to struggle. 60% of claims for long COVID are being denied because clinicians aren't measuring symptoms. So the insurance or the disability adjuster will say, oh, well, in your notes, you're just saying patient complains of fatigue. Well, that's not really enough for us to actually, do anything about that because it's just subjective. However, if you use the fatigue severity score, which, by the way, the FDA approves for drug trials, suddenly the insurance modifiers sit upright and they're like, oh my goodness, they have the same fatigue levels as someone who has a traumatic brain injury and a disorder of consciousness. And suddenly it's taken seriously. So understanding that this is very, very important, not just for you to measure the effect of your treatment, but also for these patients who are desperately trying to access benefits that they are owed, measuring your symptoms becomes very important. The second concept that I really want to drill down on, because it's super important, is I've banged on forever about long COVID so far, but also understand that if a perfectly previously healthy 30-year-old person comes to you and says, I'm short of breath, I think ever since COVID, but I don't know. I used to run 5 miles a day and now I can't walk up the stairs. Check everything out. If someone has idiopathic shortness of breath, image their lungs, look at their pulmonary function tests. If they're telling you that, at various points in the day, they'll have crazy heart palpitations and they'll feel chest pain, clear their heart. If they're having cognitive impairment, measure their cognitive function objectively, get neuropsych testing done if you feel that you need to get neuropsych testing done. If they're having overt cognitive issues, headaches and blackouts and losing parts of their day, get brain imaging. All of this is to say, the old adage of if you hear hoofbeats, think horses, not zebras. We are seeing more zebras because long COVID has infected, COVID has infected so many of our population, but also cover your bases. Don't just immediately say, oh, these symptoms are just emerging since a viral infection. It must be post-viral illness. Please cover your bases and test the basics because we see we've seen 3,000 people with long COVID at this point. In 2 to 3% of cases, we see overt organ pathology. Maybe the virus caused it, maybe the virus didn't, but it's there and it needs to be addressed before we can move forward. This is just one such example where we did echoes on 200, well, a little over 200 folks who were reporting heart palpitations and cardiac symptoms, cardiogenic symptoms post-COVID. And, across the population, in roughly 2% of cases, we saw abnormalities that, again, may or may not have been caused by COVID, but had to be addressed regardless. So this is something that is always in my mind when someone wanders into our clinic, which is, let's make sure there's not something life-threatening going on that is causing the symptoms that you're experiencing. In addition to this, to follow on from that cardiology finding, let's be clear, we tested 200 people who showed up with cardiac complaints, heart palpitations, feelings that their heart were racing, feelings that they're going to, pre-syncopal symptoms like they're going to pass out, et cetera, et cetera. And only 2% of them had abnormalities in their heart. What does that tell us? That tells us that all of these symptoms that these long COVID patients are experiencing are not, in most cases, in 98% of cases, they're not cardiogenic. So that should tell us that cardiac rehab, which is graded exercise therapy, isn't going to help these folks. That's not the right prescription for someone who comes to you and says, look, I was previously healthy, I got COVID, and now I have a racing heart and I feel like I'm going to faint when I stand up and I sweat for no reason, and so on and so forth. Putting them on a treadmill and progressively challenging them isn't going to fix that, because it's not cardiogenic. We've done the math, in 98% of cases, it's not cardiogenic. So don't prescribe it. Don't say, oh, well, I'm sorry to hear that. It sounds like you were just deconditioned from a severe viral infection that you had, and now we just need to get you back on track. So let's prescribe you some exercise. Which brings us to our final concept, which is interdisciplinary care is very much needed for long COVID care. I'm encouraging everyone I speak to who has a clinical practice to try and be as comprehensive as they can be, or as they feel comfortable being themselves. Especially in family medicine, I think it's important that these patients need a quarterback. They don't need just one more specialty referral. They need someone who is collating everything, putting it together and saying, okay, this is what is next. But understanding that, they may need neuropsych or OT for their cognitive dysfunction. They may need psychological support or social support for the loneliness and the issues they're experiencing at work and home and so on and so forth. They may need to talk to an RD because suddenly they have a million new food sensitivities. They can benefit from physical therapy with autonomic rehabilitation and breath work. All of these things are a part of the continuum of care for long COVID. The other thing that I think is super important is just the idea of following up. This is a simple idea, but patients with long COVID so appreciate it. Like, they often just get cleared by specialties and then it's sort of like, move along, please follow up and make sure that, your patients have what they need, because they're very lost in the system, and without appropriate follow-up, they're going to struggle. In terms of physical rehabilitation, I know we're running out of time, so I just want to burn through these slides. But in terms of physical rehab, the first thing that we often do is just behavioral intervention. And I know these slides are going to be shared afterwards, but We can do so much for our patients. In fact, our research and our data suggests that just following these guidelines for each of these common triggers. So we published in 2022 the most common triggers of symptom flaring for our long COVID patients. And just following this can stabilize their symptoms and improve their overall quality of life by 30%. So just having a conversation about pacing, just having a conversation about adequate hydration. And, people with post-COVID dysautonomia, they need 2 liters of water with electrolytes. It's not just, and they need it every day. And, salt will be a lifeline for these patients. So making sure that you manage their sodium intake can change their life. It can take them from not being able to tolerate sitting up to having, being able to work a full day. Planning meals, making sure that they don't get postprandial symptoms from a big meal that stretches their stomach, rather having small meals throughout the day. Environmental management, especially right at this moment, as we've gone from winter, Monday, Tuesday was winter, Wednesday, Thursday, Friday, summer. This is when your long COVID patients are going to be freaking out. Their symptoms are going to be blasting them because it's suddenly become hot. Understanding that, preparing them for that, making sure that they're, that they're doing remediation, air conditioning, staying cool, avoiding commutes, et cetera, et cetera. With the understanding that things are going to be worse for them because of the weather is very important. We've had a lot of success with breathwork protocols. We believe the reason why is that the vast majority of our long COVID patients have low end tidal carbon dioxide levels. So, and we've published on this. So breathwork that focuses on, we teach parasympathetic breathing. So, slow breath in, a breath hold, and a slow breath out. So 4 seconds to breathe in, 7-second hold, 8 seconds to breathe out. That's just a general framework. You need to personalize, of course, if someone is feeling short of breath, but this sort of parasympathetic breathing, which encourages CO2 retention and increases CO2 levels, has really helped a lot of our patients for symptom management. So again, we're not curing anything here, but we are helping them manage their symptoms. Then we refer for autonomic rehabilitation. This is a whole lecture onto itself and we don't have time, but just general principles. When I say autonomic rehabilitation, I don't mean get them on a treadmill and push them into getting over their deconditioning. This is not graded exercise therapy. This is typically what you see in this video is typically our starting point for autonomic rehabilitation, which is laying supine, doing gentle heel slides and bracing, performing abdominal bracing and very structured breath work so that this gentle movement does not cause a sudden increase in heart rate. So autonomic rehab is a very specialized rehab program. If you Google the Mount Sinai Trusted Network on the Mount Sinai website, there are a series of physical therapy practices that you will see are COVID trained, which means that they're trained in autonomic rehabilitation, which means that they won't just throw someone on a treadmill and worsen their symptoms. What we have seen with autonomic rehab is that for people who engage, so this is in 113 patients, if they engage in autonomic rehab for 3 months, we see a doubling of their activity tolerance. So 10-minute walk time halves, so they're able to walk twice as fast as they were before the rehab. We see a halving of their fatigue levels. So fatigue severity scale is an odd bird. An increase in the fatigue severity scale actually means your fatigue is getting better, not worse. So we see that their fatigue is cut in half. But what I will also point out is that we see the number of symptoms being reported significantly decrease, but it's not going to zero. These were previously healthy individuals. They still are symptomatic. So we can conclude that autonomic rehab, breath work, all of the behavioral strategies, these ease symptoms. They don't address the underlying cause, which is what we spent the first half of the talk talking about. But it's something that we can do in the meantime while we're capturing, things for blood, for drug trials and so on and so forth. The other thing that I just want to point out here is this is our 10-minute walk time across time. Baseline to 1 month to 3 months, you can see that, people are starting to see an effect around a month. At 3 months, they're really seeing an effect. All of this is to say that if you hit a month and your patient isn't feeling any better, and in fact, they're saying, oh, PT really tires me out and I don't feel good about it. And then they hit 3 months and they're still saying the same thing. I think that it's worth noting and acknowledging that this is a patient that PT is not going to help for. This is a patient that autonomic rehab isn't benefiting. So cut them off the rehab and focus on breath work and pacing and behavioral measures for symptom management until we can come up with a clinical trial to put them in. Because just throwing good money after bad, saying eventually you'll respond, isn't the answer here. And so I'm not trying to, just because I'm a PT, I'm not trying to sort of push that PT is always the answer. It's not always the answer. And in fact, as I said earlier, most of our patients don't fully recover. It's just very good for symptom management, because 70 to 80% of long COVID patients have dysautonomia, which is testable, and they can respond to autonomic rehab, but it's not the underlying cause, it's just a symptom. There are phenomenal resources on these two websites, the AAPMR website. They have really great broken down consensus documents that were produced in collaboration with patient-led organizations, as well as long COVID physio is a really good resource as well in the UK for adding resources. So I'll stop there. I have run a few minutes over time, but I hope you forgive me because this is a complex issue, but I want to thank everybody who's contributed to this work as well. And thank you.
Thanks so much. I think you convinced us that it's a complex issue. I have one question that, in the very beginning, you said there was no test for it, but then you said you could look at their blood and identify 98% of the people that had it. So those two things seem to be contradictory.
Yes.
How can you explain that?
Sorry, there are no tests that you can, there's no order set, that you can quickly test for. And so, the work we did with Akiko Iwasaki, which is published and you can take a look at, we're looking at deep immune profiling. So we're doing things that you can only do with, a scientific laboratory behind you and a world famous immunologist running the testing. Things are quickly emerging, and I hope that. I hope that we're getting there. For instance, there's a gentleman by the name of Bruce Patterson who has a company that has been testing long COVID patients since the pandemic began. And, his testing paradigm is VEGF, CCL5, SCD40L, IL-2, IL-6, IL-8, IL-13, TNF alpha, interferon gamma. And he is seeing that those things are persistently elevated in long COVID patients. But what he's trying to convince the FDA of is we need a machine learning algorithm to make the diagnosis from the blood testing, which I promise you, within the year, we're going to see machine learning assisted diagnostic paradigms. I'm not sure that's a great thing, but you know, that's where we're going for complex chronic illness, because no two patients look the same, unfortunately.
Red?
I don't want to, there's a couple of other people. I think you've hit our sweet spot, because what we do is deal with complex chronic illness every single day. And this becomes a really good opportunity for our departments to collaborate. I'm thinking of elective opportunities for our residents. I'm thinking of looking at, you know, there are access issues for our patients with insurance. And I think looking at, you know, there's a couple of comments about the tools that we could benefit from, the testing that your department does. I mean, there's, you know, after this talk, I think there's a lot of opportunity to explore and enhance collaboration.
Yeah, absolutely. I would say, you know, and similarly to address the questions in the chat as well, in terms of cognitive testing, you know, we use a software platform called BrainCheck. You know, this is not me endorsing BrainCheck. Like I said, I have nothing to disclose. I'm not a member of the company or anything like that. But and to be very frank, it's much of a muchness. There are like 100 cognitive testing tools out there. What we like about it for our long COVID patients is, unlike a neuropsych exam that takes 2 to 3 hours, so it doesn't trigger their exertional intolerances, there are billing codes, 6138 billing code, which we use for remote cognitive testing, that actually covers the cost of the test for the physician and the interpretation. And it gives you a very nice summary of, here are the well-validated, you know, they do things like the Stroop test and Flanker and Trails A and Trails B, which are like neuropsych paradigms that are very well validated. And it gives you an explanation of, this is where the patient scored, and we think that a cognitive impairment is either likely or unlikely based on the score. So those are the tools that we use for cognitive impairment. In terms of access issues, we totally hear you. We are in the process at Mount Sinai of, you know, we're building a center for complex care for long COVID patients. So we now, where you guys all know Mount Sinai, so you know that building things takes a long time, but we're seeing patients. So we have a clinical workflow, which means we have, you know, a wait list. So if you do have under or uninsured patients, we can take them, because we have philanthropy to make sure that these underinsured patients are seen regardless of their insurance status. But yeah, I you know, that's a blessing to be in New York, but we need more of that, unfortunately.
Well, yeah, I would just add one thing that we have is we have a number of integrative medicine approaches. We're doing an acupuncture study, and you didn't comment on that, but that might be something that we could look at collaborating on in the future.
I would love that. Yeah, I try to keep all the talks, because it's such a, you know, I guess I'm preaching to the choir here, and I should have known my audience a little bit better, but you know, it's such a hotly contested issue that I try and keep all of my talks very science-based. This was published in Nature. This was published in Science. This was published in Cell. We're deep into, I'm hoping, I've just received a small amount of funding this year, in fact, to study some supplements, you know, the effect of some supplements for long COVID. We have a strategic partnership with Thorne, which is a supplement company to investigate the role of supplement therapy for long COVID. And we're super interested in acupuncture as well, because so many patients are reporting improvements as a result of acupuncture. And we'd be delighted to collaborate on some studies.
Great, thank you.
I think maybe we have time for one more question. I can't see the questions in the chat.
I think I've addressed the Q&A in the chat. Yeah.
All right. Well, then I just want to say thank you. And, we were right. This was, thank you, Diane, for finding Dr. Putrino and arranging this. This has been really, really, really educational and right up our alley. Dealing with ambiguity is what family medicine is all about.
Mhm.
So thanks so much.
Indeed.
No
Thank
worries.
you.
Thank you.
You'll
Dr.
hear from us
Putrino.
again.
Yeah.
Thank you, Dr. Putrino.
Thanks, everyone. And yes, looking forward to hearing from you. Talk soon.
Thanks. Bye-bye.
Bye.